If you want to, standing in the back, you want to come and have a seat. We're going to go ahead and get started with the lecture portion of today's grand rounds. Just briefly going through some of these slides. The one relevant one is I don't have any financial disclosures to make. And these are the presentation objectives that I'll be going over in more detail in a few slides. Mental health services and ADHD is one area of my research. A lot of my research is on different topics within college mental health, and today I'm going to focus on this piece. Some of my other work relates to suicide epidemiology and prevention, as well as substance use. So going over today's outline for the talk, in the beginning I'm going to give you a little bit of background on campus mental health services. The objective for somebody listening to this section would be able to understand the landscape of the broader U.S. mental health services on college campuses. The second section will be a brief clinical overview. I think it's important whenever we're thinking about mental health services to think about the clinical entity that we're trying to treat to understand how to optimize and structure the services that are being provided for them. The objective for that is to describe challenges and best practices for diagnosing ADHD in adults. And then finally, the second half of the talk will be looking at some of my research, just one study and a very select part of that study that I want to be presenting to you. And the focus of that will be describing the availability of ADHD services on college campuses. Let's start with the background. So just a brief definitional note. I'm going to use the term colleges in a non-technical sense today. There's technically a distinction between colleges and universities in terms of the number of graduate programs and the number of staff dedicated to those programs. But I'm going to use it broadly along to refer to institutions of higher education and post-secondary institutions, just because it's a little bit easier to say. For those of you who want to quantify what college means in our country right now, there's a lot of money that's being spent in college. For those of you who are paying college tuition right now for one of your kids, that's a very painful fact. It's also important in terms of the number of students that are enrolled. There's almost 20 million enrolled in higher education in the United States at around 5,000 colleges in the US, according to some of the latest numbers. And for an individual's impact on their life, there's strong associations with college graduation in terms of increasing the income available over your lifetime that you earn, and then also on average living longer. There's probably some confounding there. People who go on to college come from different backgrounds than those who do not on average, but still an important association to know. For those of you who've been keeping an eye on some of these news outlets, you've probably read about some of the concern about college mental health that have been highlighted in the last few years. But I want to point out that it's not just a media phenomenon. There's data to back this up. The Healthy Minds Network is one of the largest data sources on college mental health in the United States, and they collect data every year at around 100 institutions, and around 70,000 in the last year is 100,000 students participating in the survey. And the data do suggest that there are increases in mental health symptoms and disorder diagnoses between 2015, which is the light blue on the left, and 2023, some of the most recent statistics available in the dark blue on the right. This has placed increasing demand on campus mental health services. Let me give you a brief background on what those services look like. So we have some research that is in the revision stage at a journal right now showing that these are almost universal on college campuses in the United States, showing that 97% of four-year colleges in the US are offering mental health services, and 80% of community colleges are offering mental health services. The scope varies significantly in terms of what they're offering, but 92% of them in that research study, that's still unpublished as I mentioned, describe their services as counseling. So I'll briefly want to give you a background on what college or campus counseling is. Campus counseling centers started in the early 1900s as a part of the mental hygiene movement, the same movement that started our FIPS clinic here at Hopkins. And the initial focus on these clinics on college campuses was really to support the academic and developmental goals of students, to prevent, not to treat, mental illness. There's some really interesting features about this sort of collection of clinics on college campuses that I want to point out to you today. Psychiatrists are often siloed and separated from therapists. 60% of counseling centers in the US do not offer psychiatric care. Sometimes the psychiatrists are in primary care, for example, and they may not even use the same medical record, which makes collaboration very difficult in a student's mental health. Financing is also quite different than what we see in other spheres of mental health care. So of institutions that do offer psychiatric or therapy care, only 20% of them bill insurance. It's very different than what we see in many community mental health models. If they do charge, most of them don't charge for therapy visits or for psychiatry visits, but if they do charge, many of these charges are just symbolic. They're $5, $10, meant to get the student to invest and take responsibility in their care. And because financing is not directly tied to the amount of services that are being provided, this often leads to rationing of services. For those of you who have had any experience or have a family member that's had any experience, if you go to a campus center, you may hear them say something like, you only have 6 visits, and then you need to be referred out to continue your care somewhere in the community. I've pointed out how college clinics are very different than what we see elsewhere in the broader sort of mental health system. But even if you look within college campuses, there's quite a bit of heterogeneity from campus to campus in terms of the scope of the services. And this often varies in terms of the size of institutions and whether they're a state school versus a private school and how selective they are, what sort of resources they might have. So just wrapping up the background section of today's talk, there's been an increasing call for research in campus mental health services. The National Academy of Sciences, Engineering, and Medicine had a 2021 report focused on well-being in higher education and pointed out there's a real need for systematic evaluation of these services that are being provided on college campuses. And that is the goal of my research, to really improve the availability and quality of these services for college students. And as I think about my research program, as I've come to present in grand rounds, I've thought about, the stages of research. And often when you're trying to get a whole new sort of domain of research off the ground, the research really has to start with descriptive work before you can start to evaluate and then think about how to improve the domain of your research. And that's where the focus of the research that I'll be presenting towards the second half of today's presentation will be focused on. So in the second section of today's talk, we're going to take a brief clinical detour, and where better to start than the perspectives of psychiatry when we're thinking about ADHD. So for those of you who are less familiar with the perspectives of psychiatry, there are 4 of them, and I'm going to go through each one of these briefly and just talk about how we can map ADHD onto this. This is not going to be an exhaustive component of understanding ADHD. To do that would take at least the whole hour, which we don't have today. So I'm just going to highlight one piece for each about how ADHD relates to these perspectives of psychiatry. So in the disease perspective, we often think about the broken part in the brain, sort of the pathology that's causing the syndrome. Heritability is a concept that essentially looks at phenotypic variation in a population and speaks to how much genetic contribution there might be to the phenotypic variation. ADHD has heritability estimates between 0.7 and 0.8, which are some of the highest in psychiatry. And we heard in the patient presentation today that there was a significant genetic component in terms of a family history of ADHD, with all 3 of her siblings have diagnosis of ADHD, as well as some symptoms in her parents. The dimensional component talks about traits that can be measured most of the time, that might vary sort of on a continuum. And many people think that ADHD is the extreme of a trait, with some of those traits being inattention that can be measured, as well as executive function or dysfunction. If you think of the pathological component of that, that could also be measured. One of the things that I love about the perspectives is that whenever you think about an individual's trait, essentially their potential, you're also thinking about how it responds to provocations from the environment. And we heard from today's patient how different environments do better or worse for her functioning. Now, life story, this is a really interesting one that I want to talk about, and there's so much more to speak about this, but with some of the increasing media presence, I think there's been a lot of positive things, which we heard from Molly again today, about how there's been increasing awareness for ADHD. But I think there's an other side to this, where inattention is really a common symptom. We heard that it's criteria for major depressive disorder, it's a generalized anxiety disorder. It can be part of many other syndromes. But there's an increasing focus of people thinking that ADHD is what explains their symptoms. When we think about the life story, we think about an individual's interpretation of their experiences. There was a recent study that suggested that 25% of adults believe that they have undiagnosed ADHD. And that number is probably a little bit higher than it's way higher than the true prevalence of ADHD in the population. So I think that is something that's probably produced by market forces and media forces. The final piece is the behavioral perspective, thinking about biological drives and how they lead to sort of repetitive learned behaviors. Stimulants are a very powerful reward in the sense that they're dopaminergic medications. Stimulants and medication treatment for ADHD is very important. And stimulants tend to have a higher effect size than non-stimulant medications for actually treating the symptoms of ADHD. But they also have a downside, which is the misuse and diversion aspect of stimulant medications. And long term, these have negative consequences on patients, showing that they increase the risk for use of methamphetamines, cocaine, and other prescription medications down the road, like prescription opioids. I want to focus just a little bit more in depth on the disease perspective, talk about a few points around the syndrome of ADHD, and think about how that might pose challenges for diagnosis before we go on and talk about my research. I briefly talked about the prevalence of ADHD. The prevalence in U.S. adults is 4.4%. This is a number that comes out of the National Comorbidity Survey Replication Study about almost 20 years ago now. And an interesting study just came out from the CDC looking at some insurance database diagnoses, finding that over half of adults with ADHD were diagnosed later in their years as an adult, which we also heard in the patient story today. Briefly reviewing what the DSM criteria are, this is sort of a shortened, condensed version, but there's 9 inattention criteria, there's 9 hyperactivity criteria. In an adult, you need 5 of either of those syndromes, or if you have both, then you have the combined subtype. You must have those symptoms for greater than 6 months, as well as having evidence of those symptoms before age 12. And that's an important piece, the sort of longitudinal trajectory, which is partly because why it's categorized under the neurodevelopmental disorders. You also must show impairment in more than one setting. So what are some of the challenges with diagnosing ADHD in adults? One of the most interesting studies just came out of an analysis of the multimodal treatment for ADHD study, the MTA study, which many of the colleagues in the child division could probably quote chapter and verse of all the citations that have come out of this. It's a very well-known study in the child division and in child psychiatry. And a lot of the research was foundational in establishing treatment for children. It did follow patients until age 25. And so a recent study that just came out 2 months ago analyzed the data and looked at the trajectory of individuals over that lifespan until young adulthood and tried to identify what were the patterns of ADHD symptoms over time. The most common patterns, 64% of individuals had a fluctuating pattern, meaning that they did not show consistent symptoms of ADHD throughout the every 2-year checks in the longitudinal study of ADHD. And they often fluctuated with the environment. Comorbidity is another challenge, and this was something else that was highlighted in the patient presentation today. When there's other illnesses present, and this is very common in ADHD, about 40%, according to the National Comorbidity Survey Replication Study, 40% also have a mood disorder if you're an adult with ADHD, almost 50% have an anxiety disorder, and 15% also have a substance use disorder. Comorbidity can be a reason why somebody may not be diagnosed with ADHD, even though they do have it. The converse is also true, and I mentioned this a little bit before, where somebody might not have ADHD, but gets diagnosed with ADHD because they come with a presenting complaint of inattention, which is very common. Some other practical challenges with diagnosing ADHD, a thorough history really takes time. In the Canadian guidelines for ADHD, they estimate it could take 2 to 3 hours at least to do a thorough evaluation for ADHD, partly because you have to go through that longitudinal trajectory of symptoms over time. A variety of diagnostic methods are also used for diagnosing ADHD in practice. If you have somebody that comes to you and say they have a diagnosis of ADHD, one really important question for me is always, how did you get diagnosed with ADHD? And then sometimes I may have to redo or reevaluate, the symptoms and take that history again for myself if I want to verify that. I want to finally close with best practices before I go to my research when it comes to ADHD. And again, a thorough clinical history is really the cornerstone of diagnosing ADHD in an individual. The print on these 4 different guidelines are really small, but these are the Canadian, Australian, European, and UK guidelines. And essentially what they sort of cohere around is this thorough clinical history. They list the elements that are in a thorough clinical history. This is no surprise to anyone. This is a FIPS history, right? And the one piece that maybe it's not in every FIPS history is the ADHD symptoms. You need to have a very close attention to that over time. There's some other things that are recommended or discussed that for clinicians should consider, which is observer reports, which the Australian and Canadian guidelines really recommend. Sometimes, especially in an adult, they may not really remember or be accurate reporters of their symptoms as a child. Semi-structured interviews are recommended by the European guidelines. There's structured published instruments that have sensitivity and specificity values that can be used as an aid for diagnosis. And neuropsychological assessment, just a brief word on this. This is something that is not required by any of the guidelines for a diagnosis, but to point out that it can be useful for identifying an individual's strengths and weaknesses, or in more challenging cases of diagnosis, for providing additional evidence to sway your opinion one way or the other. All right, so now to the research part of today's talk. I want to talk about my research describing campus ADHD services. And before I do that, just to give you the clinical understanding of what ADHD is like in college students, there's an estimated 1 million college students in the United States with ADHD. This is based on 5 to 6% prevalence rates. And there's clear evidence that there's worse academic, social, and health outcomes for students with ADHD. The study I'm going to present some findings from today is called ADHD Assessment and Treatment Services in a Sample of U.S. Colleges and Universities. I am very grateful to my colleagues who collaborated with me on this, Dr. Armand Terzian, who was a resident here and now is a child fellow at CHOP, Dr. Amin Mojtabai, who was in our department here, also in the School of Public Health, now at Tulane University, and Dr. Amelia Aria, who was at the University of Maryland School of Public Health and was formerly in the Bloomberg School of Public Health. There were 2 objectives to this study, which was published in Psychiatric Services earlier this year, and I'm really going to focus on this second one, just the descriptive piece of what campus services look like based on the data we were able to collect in this study. Brief comments about the methods. This was a cross-sectional study design, essentially meaning that we collected data from a single institution at a single point in time with a specific method. We use as our sampling frame the Integrated Post-Secondary Education Data System, which is a database kept up by the National Center for Education Statistics. And our sampling strategy was we really want to focus on four-year schools, sort of the conventional college experience. And we wanted to achieve representation from a variety of institutions. So these were institutions that were stratified by both the percent of students admitted and the number of students enrolled. And the reason why we wanted to do this is because we thought that those were key factors that would determine what kind of services a school would offer. A very large state school is going to be very different from a very small rural liberal arts school. And so we wanted to make sure we had good representation from schools in each of those sort of, if you think of it, we broke each into 3 categories, so it's a 3 by 3, 9 different cells for this stratified sample. Now, as we were doing this stratified sampling process, we found that there was very few schools in that less than 33% admitted category, that many of the well-respected institutions that we might know as household sort of names as respected colleges fit into that category. And so we wanted to make sure those were still represented. We oversampled from that group, and that just led to a consequence of we ended up downweighting those institutions in the percentages that I'm going to give you in a few slides. And finally, we selected a sample size of 200, which is essentially a benchmark for studies that look at different policies among higher education. On the right, you'll see the flow chart that sort of visualizes how we went through that sampling process, ending up with 200 institutions. The data collection, we took 6 core variables describing ADHD assessment and treatment services on campuses, and I'm going to present 4 of those to you today. We took some data from websites to see what did websites tell us, thinking about the parent or the student experience of looking to get care for ADHD. Arma and I did this together. We had a pretty high percent agreement, 92%, and a Cohen's kappa of 0.77, indicating substantial agreement as we were coding these websites. And we did that for the first 30 institutions before we went on and independently coded the rest. In terms of the survey, we also sent out a survey to try to supplement the website data collection, knowing that probably not every institution was going to have data available on their website about the services that they offered for ADHD. Now, we were only able to find information on 70 websites for institutions, and we were only able to get 32 schools to participate in the survey. I'm going to be very upfront about the transparency of, this is limited data. We started with a sample of 200, right? We did merge those 2 data sources together to try to give us a complete picture. We ended up with only 90 institutions that gave us data in the merged data set. So just a reminder, as I'm giving you these results, we didn't have complete data. So on every slide, I'm going to give you the numerator and the denominator, so you know how many schools from each category, each variable, we were able to collect data from. And then I'm also going to be giving you weighted percentages just as a brief reminder because we oversampled from the 1 strata of our sample. There's 4 findings that I want to go over, 3 related to assessment services and 1 related to treatment services. First, for assessment services, only 18 of 67 institutions offered a clinical diagnostic interview evaluation on campus. So if you're a clinician, you work at a campus center, at how many places would you be allowed to, or would you offer the ability or have the ability to do a diagnostic interview with a patient who comes into you saying, I want an evaluation for ADHD? Only about a quarter of institutions for whom we were able to get data on this issue allowed that or offered that to students. And very few institutions facilitated neuropsychological testing on campus. It ended up being 12 of 83, or 14% in the weighted percentages. I told you a few slides ago, neuropsychological testing is not required per the available clinical guidelines to diagnose ADHD. So why might that finding particularly be important? And it's because in the college space, most institutions for which we are able to gather data on this variable do seem to require neuropsychological assessment, at least sometimes, to be treated for ADHD. 57% of them, of this denominator, said all the time you must have neuropsychological assessment to get treated, whereas the other 32% said at sometimes you may be required this. And we don't fully understand when that policy might apply or not. And then finally, the fourth finding I want to present to you today is the amount that offers stimulant treatment for ADHD. About half of institutions, 49% in the weighted percentage. One thing we had considered looking at, which we just didn't find in our initial test samples, was whether or not institutions would say whether they offered therapy or executive function coaching or other non-pharmacological treatments for ADHD, and we just simply didn't find that on websites, and so that wasn't something that was ended up as part of our formal variables that we collected as we went through the survey, went through the sample. Just for findings, what are some of the significance of these findings? Just taking a step back. So something I told you at the beginning of today's talk was that most colleges do offer mental health services. There's an opportunity there. There's infrastructure on college campuses for offering services for a variety of health conditions, mental health conditions. And you might think that there's also a reason to maybe offer services for ADHD, as it's associated with worse outcomes for students, including academic outcomes. But there must be something more complex to the story, because ADHD services are largely excluded from the services that are offered on college campuses. And so on the next slide, I just want to share some of what I've understood from the field in terms of some data that's available in my time in this professional spaces in this field about what might be the reason why these findings are this way. So why do few schools offer clinical diagnostic evaluations? And one of the things I want to point out is that there was a really interesting study, one of the only other studies that looks at campus services for ADHD. And in this study, there was 300 clinicians that were interviewed from 43 different states in the US. They were asked a couple different questions. One of them was, how comfortable are you with recognizing ADHD in a patient? Not diagnosing, just recognizing ADHD in a patient. And only half of them said that they were comfortable recognizing ADHD in a patient. The second question was, if you were to have to do an evaluation or to diagnose somebody for ADHD, would you do it yourself or would you refer out? And 92% said they would refer out. Only 8% of clinicians in this survey said that they would diagnose it themselves. I think there's also, I've mentioned earlier, that there's challenges in terms of the resources that are available on college campuses, and I think that another reason that we don't have data yet to back this up, but we're trying to put together a qualitative study to investigate this, is that it just may not meet the priorities for college clinics. Some of the things we found on websites, just qualitatively speaking of what we were reading, there was one that stands out in my mind where it essentially says that we've had so many increases in requests for ADHD evaluation, but we have many other high-risk psychiatric conditions that we need to take care of, and therefore to not jeopardize the care of these other conditions, we are not going to offer treatment for ADHD. The second finding was that few schools offer neuropsychological assessment, and I think the point here is, I think, fairly obvious. These are costly. To hire staff to do these, they take a lot of time. To hire the ability, pay for the ability to offer this to your students is quite costly. But why are many schools requiring it? And I think it might speak to the fact that many clinicians on college campuses just don't feel comfortable diagnosing or evaluating it. And so there's kind of an inbuilt, robust evaluation way to do that, which is neuropsychological assessment. And this is probably also not a surprise, but many schools are not offering stimulant treatment, and I think the reason may have to do with concerns about misuse and diversion. We published a piece earlier this year in the American Journal of Drug and Alcohol Abuse, where essentially we took all the 14 substances that are evaluated by the National Survey on Drug Use and Health. We took 18 to 22-year-olds, divided them into those full-time enrolled in college, those not enrolled in college at all, and then we looked at the odds ratio associated with college enrollment with use of each of these substances. So Arrows pointing to the right or bars pointing to the right means more common in college students. Bars pointing to the left, less common in college students. And at the very top of the list, the substance most associated with college enrollment is prescription stimulants. So this is certainly a concern. A couple limitations before I wrap up. One thing is that there was disagreement between survey data and web data. There was only 65% agreement for the schools that gave us both web and survey data. There may be a little bit of a trend when we looked at that closely that perhaps the websites were overrepresenting what they were offering, where survey respondents actually said we're not offering those services. The other piece, which I've mentioned multiple times, is the missing data. We had 90 institutions with data, 100 without, 110 without. And when I looked at what described or distinguished those two, there was more large institutions and more state institutions in the group on the left, meaning smaller private schools were more on the right. What that means for what those schools look like in terms of the ADHD services, still don't know. I think there were some strengths I think we should also point out. I think the reliability statistics that Armand and I put together were pretty robust in terms of what we gathered from websites. I think the two sources of data, even though both were incomplete, allowed us to think about those 12 schools and think about the data in a little bit more of 3 dimensions of what might be missing. And the other thing I'll point out is that our data really closely matched industry data. There's a telehealth company called Mantra Health, which focuses on providing mental health services to colleges. And they had a confidential industry study that they carried out with 300 clinicians in the US that worked at college campuses. And their results, which they gave me permission to share with you today, were almost exactly the same as what we got in terms of the 3 variables that overlapped between our work and their work. The numbers were quite similar. Now, just in closing, bringing you back to sort of this research cycle, thinking about how can we strengthen descriptive research in this area, and then I'll talk about how we might be able to move towards evaluative research in this area. I think websites are going to be limited, not just because they're distant from practice and on-the-ground reality of what clinicians are doing, but because also many schools don't have the ability to keep their websites updated and accurate. I think surveys, if they're going to be a strong source of data on this, are going to need to increase their response rates. And I'm glad to say that I'm now partnering with the Healthy Mind Study, which is that brand of college student mental health research, to collect data from institutions. And we learned a lot doing this when I was a postdoctoral fellow with Armand as my colleague and collecting data, but I think we're going to have to take steps to improve some of the data that's collected. And then the qualitative methods offer depth as well, I think, for understanding the reasons why services are the way that they are. Moving to evaluation, the other piece to start to evaluate services, we would need to link the services to data on the students at that campus themselves, or the students who are using those services. The Healthy Minds Network, again, provides an opportunity to do this because they collect data from over 100,000 students each year in their work. And as we collect data from institutions, we can merge it with data from the students. I've also thought a lot recently about how medical record data might be able to lend itself to this type of research. But it is a fascinating field out there where there's so many different medical record systems in college mental health, and not all of them are equally apt at providing the data for research as EPIC might be. So in conclusion, the first section today, campus mental health services are almost universal on college campuses, but they're quite heterogeneous and unstudied. ADHD is a complex syndrome. Diagnosis requires care and time. And campus ADHD services, according to the early research that we've done, especially diagnostic services, appear to be quite limited. There's so many people I have to thank. I put a lot of names on the slide. I'm sure I missed somebody, but I'm very grateful for all the support for some of this research that I've been doing. And I'm very happy to take any questions. Thank you.
Thank you, Dr. Laurie. Wow, that was a fantastic first grand rounds. It was really a model of thoughtfulness and of clarity. Just superb. One thing that struck me was the discussion about how the diagnosis of ADHD requires something resembling a FIPS kind of assessment. But it made me think about the issue of reliability of the diagnosis. Has anybody ever done a study where you take reliability in the community and compare it to gold standard reliability of a careful research diagnosis?
Nobody's done that. There have been a couple reliability studies. Some have looked at some of these different semi-structured interviews, but even those are in the hands of sort of ADHD experts, right? And the reliability for those look like 0.7, 0.8, pretty good numbers. Another issue I've looked at is whether or not there was ever reliability studies in DSM-5 as they were doing field trials, and it was never part of the adult ADHD was never part of the interreliability statistics when they were looking at that for new construct and criteria for DSM-5. And I'm not entirely sure why. I've asked the APA why, but there's no good answer for that. So nobody's done your study. Somebody have looked at, the optimal case where there's clinical experts who are comparing each other. So.
Great. Okay. Thanks, Dr. Swartz.
Of course. Yes, so...
You want to repeat the question?
Of course. So the question was essentially, what are we doing at Johns Hopkins Student Health and Wellbeing and the mental health services for ADHD? Now, Sean Heffernan, who was a trainee here many years ago, not many years ago, about a decade ago, has been a fantastic addition to mental health services. He's the director of psychiatry, and working together with really, a lot of it was Sean's work. He has been putting an effort to sort of think about how we offer ADHD treatment and services. And so essentially we have an intake where you'll do the full evaluation. I often in practice will do sort of like the FIPS evaluation first, and then if I think there's reason for a second evaluation, we have the space to bring them back for a second evaluation before we need to do a diagnosis of ADHD, before we think about treatment. For those who we think might benefit from stimulant treatment, we will then ask them to sign a medication agreement to sort of mitigate that diversion and misuse piece. And we go through a very thorough conversation about that. One thing that's really fantastic as well is that now they're offering an additional set of services for students who might have ADHD. We're now paying for neuropsychological assessment for students that we think might benefit from it. And they're also offering executive function coaching for students who particularly have difficulties with executive function. So the addition of those extra services for students with ADHD, and I think a flexible process that has structure to it in terms of how to go through the diagnosis, I really appreciate it in what I've seen in the sort of revamped system that Sean's been spearheading.
So it sounds like we will have a real gold standard sort of system at Hopkins.
I think it's pretty good.
Yeah, that's great. Other folks? Dr. Scharf. We should.
Yeah, so Dr. Scharf, thank you for the question. Dr. Scharf always asks very insightful questions about, essentially the question is somewhat, what's considered normal? Where do you draw the line, essentially, between what's considered normal, what's considered abnormal, and how does the specific academic demands of the college environment sort of sway where the line might get drawn? The bigger question about what's considered normal and abnormal, you have to kind of look at the student's environment, and you have to look at the impairment that they're providing, and you really have to be thinking about how those two interact with each other. The question about the college environment is a really good one, and we often see people who are very intelligent, they breeze through elementary, middle school, high school with great grades because they didn't need much effort. When they come to the college environment, they all of a sudden, or maybe it's not that step, it's maybe the college environment to medical school or the college environment to graduate school where they're doing a PhD. They may find that change in environment then unmasks some of the difficulties with functioning that they may have, and we see that quite frequently. I don't have, the question you ask about where exactly do we draw this and what would happen if that person wasn't in this environment, should they still be diagnosed and treated for ADHD? It's a complex one, but really speaks to the importance of the perspectives and thinking about the dimensions and how it interacts with a particular person's environment.
Dr. Onyike.
Can you ask the question one more time? You're, Sure, and there's so many different reasons why a person might manifest symptoms in a particular area. And sorry, just to rephrase, so I think you're pointing out that somebody might have symptoms, they might have symptoms that are unmasked because they were subclinical before, but they may also just not have the right preparation or skills, if I'm trying to. So yes, I think both of those are possibilities that an individual might have when they switch environments.
Dr. Yue.
Yeah, so that's a very non-specific criteria. The criteria simply says you must have symptoms. It doesn't say you necessarily have to have impairment before age 12. And so what you'd be doing is you'd be looking for some of those different symptoms, trying to identify were there ones that they might have had earlier on, even if it maybe didn't cause impairment in that specific environment, is the way I might approach that.
Dr. DiPaolo. Time is short, right?
Yeah, the question was essentially, when there's comorbid psychiatric conditions, how do you determine how salient ADHD is? You know, I haven't looked at this specific in clinical guidelines, so I don't know if this is founded from that or just sort of what's discussed in the clinical community that focuses on ADHD. But often there's sort of a kind of a hierarchical approach where you may focus on treating mood disorders or anxiety disorders first. Substance use disorders might also go near the top of the hierarchy, and then focus on the ADHD later down the line. So that's how you might approach it when there's multiple comorbid conditions.
Thanks. Last question, Dr. Brandt.
Yeah, Dr. Brain asked a question about how to handle misuse or diversion and maybe deprescribing in certain cases. Because of the time, this is a very complex issue, but I would say generally there's not evidence of good, strong, sort of consistent policies across colleges about how to handle that particular issue. There are a couple areas where people have studied. Maybe are there ways that we could have a conversation before these medications are prescribed that seem to decrease diversion or misuse? And I'm happy to talk to you about some of that literature after. Thank you.
Great. Thanks so much, James. That was really superb.